So you will have a set of drug cards due on Wednesday, and then there's a new assignment up that'll be due on the following Monday in Canvas already. Okay, so before we go live into the IVs, I want to talk real quickly about cardiovascular, or at least the foundation for understanding the basics of cardiovascular pharmacology. And that's through the agency of something known as the Vaughan Williams classification of antidysrhythmics. It's not perfect, and it doesn't take into consideration a lot of the nuance of how some of these agents work, particularly very complex agents like amiodarone. It oversimplifies them, but it's a good foundation, it's a good starting point for understanding. So the first thing that we need to realize, we need to recognize, is that tissues in our heart depolarize a little differently. And we can generally group cardiovascular tissues, or cardiac tissues, into one of two areas. Either your nodal tissues or your non-nodal tissues. Okay? So your nodal tissues are tissues that exist within your primary pacemakers, your SA node, for example. This would be a good example of how the SA node depolarizes versus how tissues in the ventricles would depolarize. So you can see it's a little different. And so what we're doing here is these little graphs, and of course you guys had the videos, these little graphs are not an electrocardiogram or an ECG like this. See, you're used to looking at activity in the heart via this, right, a PQRST complex. Okay. What these are looking at these are not necessarily looking at the electrical activity, although it is a way of looking at the electrical activity, but these are looking at the potential across the myocardial membrane. So it is a membrane potential as a function of time. Okay, that's what's being graphed here. Okay, membrane potential, okay, as a function of time. All right. So to understand these, the first thing we need to understand is what's going on with this whole membrane potential thing. So here I've drawn the basics of what's going on. I have the extracellular space and the intracellular space. All right. And what we have is, where is most of the sodium in the body? Where's most of the sodium in the body? Y'all throw that right out at me. Extracellular, right? Where is most of the potassium in our body? Intracellular, right? Okay, so here I have sodium, extracellular, and I have potassium, intracellular. And then we also have these negatively charged molecules within our cells. They're typically proteins, okay, that are anionic, okay? So if you were to compare, so you look at the charges on the potassiums here, right? You look at the charges here, and then you look at all the charges on the sodium. What do you notice? Do you notice kind of a disparity? There's more positive charge outside of the cell than inside of the cell. Would you guys agree? So would you also agree that the inside of the cell is negatively charged when compared to the outside of the cell? Does that make sense? All right. Okay, so this is what's known as the resting potential. Okay, when nothing particularly interesting is going on. All the sodium's outside, all the potassium's inside, okay? And calcium, of course, is involved, but we'll get to that. So you have the potential across the membrane here, across the cell membrane, is negative. Does that make sense? So let's start at our nodal tissues first, okay? So if we look at our nodal tissues are what we call permeable. They are permeable to sodium. That is to say that the nodal tissues have sodium channels that constantly leak. So there's constantly a flow of sodium going from outside to in. Does that make sense? Okay, there's just a constant flow of sodium. So what happens is, in phase 4 here, phase 4 gradually moves up. Okay, so we're starting at negative 60 millivolts here for our nodal tissues, right? and it's moving up, it's moving toward the positive, right? So that means sodium is coming in, right? Slowly entering these cells during phase 4 until, okay, there are channels, okay, there are channels that detect the membrane potential. And when that membrane potential reaches about negative 40 millivolts, that's known as the threshold potential, okay? Threshold potential. And in the case of the nodal tissues, these are calcium channels. And once that threshold potential is met, okay, slow leak of sodium in, and then the threshold potential is met, then the calcium channels all open up very quickly, and calcium rushes into the cell. What kind of charge does calcium have on it? Is it an anion or a cation? It's a cation, has a +2 charge, right? So you have a large amount of positively charged ions flowing into the cell, right? So what's going to happen? It's going to happen to that membrane potential. It's going to rocket up toward the positive, right? All right, so here I have my sodium leaking in, threshold potential, calcium rushes in during phase 0, okay? And this is what we mean by depolarization, right? Okay, the potential depolarizes. It moves from a negative potential to a positive potential, right? Its polarity changes in essence, all right? And then once all the calcium moves in, once there are channels that sense, okay, that we are at that about positive 10 millivolts, then the calcium channels or the potassium channels open up, and where is most of the potassium? Inside of the cell. So where does it want to go? It wants to move outside of the cell. So what happens is calcium rushes out of the cell, and so I have what kind of charge moving out? Positive charge. So what's going to happen to the membrane potential? It's going to drop down, right? Make sense? It's going to drop down as potassium leaves, and then you have the sodium-potassium pump working, okay? And what it's going to do is it's going to reset everything, okay? The sodium-potassium pump is going to pump the sodium out, pump the potassium back in, okay? And we're going to reset. But remember, I always have those leaky sodium channels. So guess what happens? It starts all over again, right? This is what makes these cells pacemaker cells, is that there's this constant leaking of sodium, right? Right? Constant leak, boom, constant leak, boom, constant leak, boom, right? And it depolarizes. Okay, it's what we call its automaticity has a certain set rate. Does that kind of make sense? Now I can change that, right? I can elicit a sympathetic response, and a sympathetic response is going to make these leakier, which will make this depolarize faster, right? And that will, of course, that's the automaticity. Does that make sense? Okay, so that's how nodal tissues work. So it should come as no surprise that when we want to affect nodal tissues, okay, we use medications, okay, we tend to go with medications that are very good at acting upon channels where you have fast-flowing ions, such as calcium channels, right? And when you administer a calcium channel blocker, such as diltiazem, for example, which is in your guys' scope of practice, right? Diltiazem is very good at slowing this down, right? Slows the flow of calcium through there. It prolongs that out a little bit, decreases the automaticity, and it slows the heart rate down. Does that make sense? Okay. You guys okay with that? Okay, cool. So those are your nodal tissues. Now, moving on to our non-nodal tissues, these depolarize a little differently, okay? So I still have phase 4, okay? Phase 4 is a resting potential. Same resting potential. It's at about -90. But what do you notice about phase 4 here? It's flat, right? Non-nodal tissues are not as permeable to sodium. So you don't have that constant flow of sodium into them. So non-nodal tissues don't make very good pacemakers. Okay, and when you see all of your primary pacemakers fail and you develop like something called an idioventricular rhythm or ventricular escape rhythm, is it particularly fast? It's very slow, right? It's very slow, very wide, complex rhythm. Why? Because those non-nodal tissues are not particularly permeable to sodium. Right? You don't have that constant leaking of sodium into them like you have in your nodal tissues. Okay, so phase 4 tends to be very flat, okay, until these tissues are stimulated. Something stimulates them. Typically, these tissues are stimulated by depolarizing nodal tissues. So a nodal tissue would depolarize, okay, and then that depolarization will activate sodium channels, okay? So instead of calcium moving into the cell, during phase 0 in non-nodal tissues, it's sodium rushing into the cell. Does that make sense? So here, calcium causes the phase 0 to go up, and here, it's sodium rushing into the cell, okay, causing that depolarization. Now, once you get up to about positive 40 millivolts, something interesting happens, okay? Here in phase 1. So what happens in phase 1 here is calcium channels open, or not calcium, but rather potassium channels begin to open up. What kind of charge does potassium have? And is it going in or out of the cell? It's out, because most of the potassium's in, right? So what happens as potassium goes out of the cell? The membrane potential moves down toward negative, right? But it doesn't keep going down like you see here, right? What happens is calcium channels open up shortly after the potassium channels open. And then calcium begins flowing into the cell, right? So I have calcium flowing in, offsetting the potassium flowing out, and so what happens is it equalizes out, right? I have equal amounts of positive and negative charge moving out and in, and I get what's called a plateau. That's what causes the phase 2 plateau, is calcium is moving into the cell at the same time potassium is moving out of the cell. Does that make sense? It plateaus out, and then I move into phase 3 where my calcium channels close, but my potassium channels remain open, which means potassium continues to flow out of the cell until I go back to my negative 90 millivolt potential, and I move into phase 4, and then the sodium-potassium pumps pump the sodium back out, the potassium back in, and I get ready for the next depolarization. Are you guys cool with that? Does that kind of make sense? I'm not getting some reassuring looks. Yeah? Yeah? Okay, okay.
This is going on when this is like the last part where like the Purkinje fibers and everything is going on, right?
Yeah, so you could roughly look at this as the atria right here, because this is the SA AV node, and then these are the ventricles here, the ventricular tissues. You could roughly look at it like that, and you would be pretty accurate. Generally, the lower down into the heart you get, the more you're going to look like this. Yeah, so definitely like your his Purkinje fibers are going to look like this. Your ventricular tissues, your bundle branches might look maybe a little more like that, but yeah, that's a good general way of looking at it. So when we look at the PQRST, you know, your P wave, right? What you're looking at here is your P wave, you're looking at the nodal tissues. your QRS complex, you're looking at phase 0, phase 1, and phase 2, primarily of your non-nodal tissues, and then the T wave is you're looking at primarily phase 3 of your non-nodal tissues. So that's how these relate to the PQRST complex. You guys okay with that? Makes sense? Cool. So now what we do is to understand how most antidysrhythmic agents work is to understand what electrolyte, what channel that drug works on. And that's really what we're doing, is we're inhibiting the flow of ions in and out of the heart. Okay, that's how most antidysrhythmics work, for the most part. There are miscellaneous ones that work a little differently. So let's talk about them. So the class 1 agents, the Vaughan Williams class 1 agents, okay, what ion do these work on primarily? Sodium channels. And there are 3 classes of 1. There's class 1A, there's class 1B, and then there's class 1C. Now, all 3 of these work on sodium channels, but they have different affinities, and they can work on slightly different channels, okay? So your 1A agents tend to work on your fast sodium channels, okay? And what the 1A agents tend to do is they tend to decrease the slope of 0, like this. And that causes a prolongation, okay, a prolongation of the action potential. Yes, sir?
And it's for the non-nodal tissues, for that one?
Primarily non-nodal, yes. Yeah, because these sodium channels here are kind of like slow, leaky. Think of them as kind of slow, leaky. These channels here are not as affected by the 1A agents. In general, all the class 1 agents tend to affect sodium channels here in these tissues as opposed to these tissues. There's obviously crossover, but we're just trying to simplify it for understanding. All right? And this distance here, from here to here, is known as the refractory period. And the refractory period is a period of time in which the heart does not like to be stimulated to depolarize again, okay? And so if you stimulate the heart during the refractory period, it may cause it to go into a lethal dysrhythmia like ventricular tachycardia or potentially ventricular fibrillation. That's important for you guys to understand because the class 1A drugs prolong the refractory period, right? So there's more time for something to go wrong, okay? And anytime you prolong the refractory period, that prolongs an interval on the ECG known as the QT interval. Okay, the QT interval. You're going to learn all about this in ECG. You will learn how to calculate it. You will learn the corrected QT interval, which is what we're most concerned about. But for our purposes here in pharmacology, okay, the class 1A drugs and the class 1C drugs, 1A and 1C drugs tend to prolong the QT interval, which makes the heart more vulnerable to develop life-threatening dysrhythmias. Wait a minute, what are class 1 agents used to treat? What do we use those drugs to treat? Life-threatening dysrhythmias. But what's a side effect of them? Life-threatening dysrhythmias. That's one thing you guys need to understand is most of these antidysrhythmic drugs are pro-dysrhythmic. They can cause dysrhythmias, okay? So it's a very delicate minefield that we have to tap around when it comes to treating dysrhythmias with these drugs because these drugs can cause dysrhythmias. Okay, so Is there a class 1A agent that is within our scope of practice? I'll give you a hint. It starts with P. I bet you know. Procainamide. Procainamide is the classic 1A drug. It's in our scope of practice. Now, class 1C, there are no class 1C drugs in our scope of practice, so we don't have to worry about the 1Cs. The 1B agents, actually what they do is they prolong the action potential here at phase 0, but they narrow it a little bit here at phase 3, which means overall they don't prolong the QT interval, okay? So the class 1B agents do not cause the QT interval prolongation that you see with the 1A and 1C. Is there a class 1B agent? Lidocaine is the classic 1B agent in our scope of practice. Okay, you guys cool with that? Mm-hmm. Okay, so that's class 1. Class 1 drugs is the sodium channel blockers. You have 1A, 1B, 1C. Fast, intermediate, and slow. Okay, and then we move on to class 2 agents. What are the class 2 agents? These are the beta blockers, right? The beta blockers, where do you suppose most of the effects of your beta blockers are going to be? Here in the non-nodal tissues? The nodal tissues. Beta blockers predominantly affect nodal tissues, okay? So you block beta 1 receptors, okay? And what do? These tissues are less likely to depolarize, right? Slows the rate of depolarization down, which is going to do what to our heart rate? It's going to slow the heart rate down, right? Which may do what to our blood pressure? May decrease the blood pressure. What will do, might do what to our contractility? May decrease it, etc. Okay? But their primary effects are on nodal tissues, right? And there are 2 general classes of beta blockers, right? There are your cardioselective beta blockers and your non-cardioselective beta blockers. What is the only cardioselective or the only non-selective beta blocker that we have to worry about at our level? Nitro is not a beta blocker. Oh, metoprolol is not. Amiodarone is not a beta blocker. Although it does have beta blocking effects, it's not considered a classic beta blocker. You guys need to know this because this is critical. This is critical. This is how we can kill people so easily. It starts with P. Propranolol. You need to know this, guys. Propranolol is a non-selective beta blocker. The reason you need to know this is if you are carrying this and you are thinking about giving this to a patient, you need to understand that there are some patients you should not give this to. Okay? For example, what kinds of patients should not get a non-selective beta blocker? Can you think of a situation where it might be deadly dangerous to give somebody a non-selective beta blocker? Well, okay, yeah.
COPD.
Why COPD?
Because it constricts the bronchus, correct?
You're on the right track. You're on the right track. It's a little more nuanced than that. How do we treat people that are having bronchospasms? We give them what? We give them beta 2 agonists, right? Albuterol, levoalbuterol, right? Our primary rescue agents are short-acting bronchodilators. A non-selective beta blocker is going to do what to beta 2 receptors? It's going to block them, right? It does not care. That's why we say it's non-selective. It does not care. It blocks all beta receptors, right? So if you have somebody that has a history of reactive airway disease, a history of asthma, and a history of COPD, and they are on short-acting beta agonists, SABAs, they probably should not receive a non-selective beta blocker, right? Okay, they're an SVT, or right, and you want to treat that with a beta blocker. You definitely do not want to treat them with a non-selective, right? Rather, you want to use a cardioselective beta blocker, like esmolol, for example, would be a very highly selective one. Now, there is one beta blocker that is a little different in that it also blocks alpha receptors as well. And which one is it?
Is it the
No, that's actually not one in our scope, so you don't have to worry about that too much. But it is a mixed alpha and beta blocker. Yeah, it blocks both alpha and beta. It blocks more beta. It's a 7-to-1. 7 beta receptors to 1 alpha receptor, but it will still block alpha receptors and cause some vasodilation. What is it? What? Epi? Epinephrine is definitely not a beta blocker. Huh?
Would it be labetalol?
What do you think?
Because it's a beta 1 and alpha 1.
There you go, labetalol. Yes, labetalol. Or I believe it's normodyne. Is it normodyne is the trade for labetalol? One of the trades,
I'm
yeah.
sorry.
No, that's okay. Yeah, labetalol. Labetalol is both an alpha and beta. All right. Your other ones like metoprolol, esmolol, okay, are cardioselective. They are more selective to beta 1 receptors. You guys okay with that? Those are your beta blockers. Okay, class 3. What do we say about class 3? These are what we call the potassium channel blockers. So they are going to affect phase 3, and they're going to prolong phase 3, which means what to the QT interval? What are they going to do to the QT interval? They're going to prolong the QT interval, yes. All right? So 1A, 1C in class 3. What is the classic class 3 agent within our scope of practice? Amiodarone, yes. Now amiodarone has more effects than just blocking calcium channels. It has blocking potassium channels. It has calcium channel blocking actions. It has beta blocking actions. It mimics thyroid hormone. It has some very complicated pharmacology. But we say primarily its role is that of a potassium channel blocker. You guys okay with that? All right, you okay with the dose of amiodarone? You should know this because this is a frontline cardiovascular drug, right? So if your patient is in VTAC or VFib cardiac arrest, the dose is what? 300 milligrams IV push, right? Followed up by an infusion. Huh? And we're going to have to learn about the infusion because it is a complicated infusion. Now, if they are not in cardiac arrest, rather you're using it to treat a ventricular tachycardia with a pulse or some sort of SVT or an AFib or something like that, what is the dose? 150 milligrams slow IV, right? This is not IV push. Now, in cardiac arrest it is, but in this case it's not. It's slow IV, right? Over 15 minutes. You load them over 15, 20 minutes, and then follow up with a slow infusion. Okay? You guys go with that? Okay, so that's class 3, and then class 4 is what?
Calcium channel blocker.
These are your calcium channel blockers, right? And you have 2 general categories. You have your dihydropyridines and your non-dihydropyridines. And your non-dihydropyridines tend to be more nodal specific, right? So something like verapamil is a classic non-dihydropyridine that is going to really impact your nodal tissues. It's going to impact the heart rate pretty significantly. Your non-dihydropyridines can impact the rate. Something like diltiazem, for example, can decrease the rate, but they can also impact smooth muscle, right? For example, smooth muscle in your blood vessels and cause vasodilation, right? So if you were wanting to treat rate, you're going to want to choose an agent that affects the tissues a little more. Something like diltiazem or verapamil. If you're wanting it for blood pressure control, you may want to choose something like nifedipine, Procardia, for example, which is actually not an agent that we have in our scope of practice. Okay, you guys go with that? Diltiazem is the classic drug that we have in our scope of practice. In fact, AMR carries it here in Las Cruces. I presume Fire may carry it as well. Okay, so it's out there. It's relatively commonly used. All right. It's a loading dose. You give them a loading dose and then you follow it up with an infusion. Okay, and then finally our class 5 are our miscellaneous agents. And what are the 2 major agents that fall under the umbrella of your miscellaneous? Adenosine, magnesium sulfate, and digoxin. Yes, right? Digoxin's not in our scope of practice, but you need to know about digoxin because so many people are on it. Okay? People with AFib, this is a very common drug people take that are in atrial fibrillation because it causes an increase in calcium ions in the cell. And the increase in calcium will decrease the heart rate. At the same time, it will increase contractility. All right. So occasionally, we also see some people in congestive heart failure are on digoxin as well. Okay. Unfortunately, digoxin can become highly toxic. It's very easy to develop digoxin toxicity. And one thing that you need to understand is potassium imbalances. Anytime there is a potassium imbalance, your patient can become toxic on digoxin. Right? Digoxin is very good at causing all sorts of dysrhythmias as well. One of the classic things that we see is a change in vision, visual changes. Green halos around light, yellow halos around light. That tends to be kind of a classic thing. Not everybody, but if somebody's complaining of something like that and they're on dig, that is an indication they may be digoxin toxic. Okay? Adenosine does not work by any of these mechanisms. Adenosine actually attaches to its own receptor. And I won't go into it because they talked about that in the video. It has its own receptor. But basically what adenosine does is it blocks conduction through the AV node junction. So it basically induces a high-grade heart, what we call a heart block. It blocks the top of the heart from talking to the bottom of the heart temporarily, right? Its half-life is very short. It's about 6-second half-life, so it doesn't last very long. But it's very quick, and we tend to use it for what? Very rapid dysrhythmias, right? SVTs and those kinds of things. Okay, you guys go with that? Okay, so that's your run-through. Some of the major antidysrhythmic cardiovascular agents that we use. And in general, you can look at it as your class 1 and 3 agents work in the ventricular tissues, and your 2 and 4 agents work in nodal tissues. That's just kind of a general way of looking at it, right? 1 and 3 work in your ventricular tissues, 2 and 4 work in your nodal tissues. Okay, if we're just being super generalized there. Okay, you guys go with that? We don't need to go into too much more detail than that because you're going to have a whole semester, the whole second half of the summer you will spend learning about ECG rhythm interpretation, and you will go into that in a little more detail. And then when you start off in cardiology in August, we'll take advanced cardiac life support and we'll actually start using some of these drugs in clinical scenarios. So this is basically forming just a foundation for what's to follow. Okay, you guys good with that? All right, cool. Well, let's take a quick break.